Okay, it's time. So we want to start the August FARO webinar. Good afternoon, and this is Mariko Kawamura from Nagoya University, and this term is by JASTRO. But before we move on to lecture, I would like to ask Dr. Vashistha, who's the Vice President of FARO, for the welcome remark. Dr. Vashistha, please.
Okay. Good afternoon and good evening, everybody. And first of all, I congratulate Dr. Mayank Premlata to continuing the FARO webinar and teaching and spreading the how to enhance our knowledge by this FARO webinars. Congratulations again, Dr. Mayank. You are so much contributing, and everybody and every FARO country party, they are participating and doing this regularly. Now I must congratulate and thanks to JASTRO for doing this webinar. Talking nowadays, how drugs combined with the radiotherapy is the main objective to increase the response rate of radiations. And for that, we must know when we have to use the drugs with radiation, timing of drugs, and at the same time, how to handle the side effect of the combined treatment. For this, I think Dr. Satoaki Nakamura has done his hard work to enhance our knowledge by this, how to use and this. And again, I congratulate and best wishes to all members to enhance them. All the best. Thank you.
Thank you, Dr. Vashistha. So now we have Dr. Shigematsu, President of JASTRO, will welcome you all. Do we have his video or to start? Thank you.
Good evening, everyone. Welcome to 17th FARO Webinar. I am Naoyuki Shigematsu, the professor and chairman of Keio University. FARO Webinar was started on 2020 with the topic of radiation oncology services during COVID-19 pandemic era. In these days, Japan has entered a heavy seventh wave of COVID-19, but hopefully it will peak out soon. From the third webinar, head and neck, breast, bladder, liver, prostate cancers, and brain tumors were discussed, as well as proton therapy and TBI. The topic of this time is drug-combined radiotherapy, which becomes lately considerable attention by radiation oncologists. We will have the special lecture by Dr. Satoaki Nakamura from Japan, and a panel discussion by medical oncologists from Japan and Philippines, and neuro-oncologist from Thailand. I am very excited to listen about the topic, especially combined therapy with immunotherapy. I hope this webinar today would like to meet your expectation. Thank you.
Thank you. So we are ready for the webinar. Today we have Dr. Satoaki Nakamura with, photo. Sorry, photo first.
Okay,
yes,
so
please.
yes, okay, thank you, Dr. Mariko. I am Mahesa from Indonesia, from IROS Aurora. I will be assisting you in taking photos. The professor and doctors, kindly turn on your video so we can take a good picture of you. Okay, so I'm going to take photos on the count of 3. Please hold still for for a second so we can take clear picture of you. 1, 2, 3, smile. Okay, maybe once more. 1, 2, 3, smile. Okay, the picture has been taken. Thank you very much. Back to you, Dr. Mariko.
Thank you. I almost forgot. Sorry. So we are now really ready for the webinar. Today we have Dr. Satoaki Nakamura with us for to give lecture. Before we move on to his lecture, I'll give a brief introduction of today's speaker. Dr. Satoaki Nakamura is a professor of radiation oncology at Kansai Medical University. He is very well-known radiation oncologist in Japan for his great contribution to education. He has won multiple excellent education awards, and he is now running weekly oncology webinar in Japan. So he is, of course, an expert of radiation oncology, but he is also knowledgeable about oncology in general. So the title of his talk today is Drug Combined Radiotherapy. And this is, I think, thought-provoking topic for all of us. So Dr. Nakamura, could you please start your lecture?
Thank you, Dr. Kawamura, and hello, everybody. I'm Satoaki Nakamura from Kansai Medical University, Osaka, Japan. Today, I look forward to discussing this with you today. I'm giving a lecture on drug combined radiotherapy. I will begin immediately. Just a moment. Is that okay?
Yes, I can see.
Okay. Today, I'd like to discuss the combination of radiotherapy and drug therapy in the historical context and future outlook. The background of this slide is a picture of Osaka Castle and the surrounding skyscrapers. I hope you all come to Osaka when COVID settles down. I have no COI with regard to my presentation. First of all, I'd like to take a look back historically at the evolution of cancer treatment. Surgery was the earliest method of cancer treatment. This photo is taken from Wikipedia, but the beginning of cancer treatment started in the 17th to 19th century. Surgery was initially performed without anesthesia, mainly for breast cancer and other cancers. In 1895, Dr. Röntgen discovered X-rays, and he was awarded the first Nobel Prize in Physics for this achievement. The year after the discovery of X-rays, radiotherapy for cancer, especially skin cancer, began. In other words, radiotherapy for cancer has a history more than 100 years. In the area of cancer drug therapy, hormone therapy is officially considered to be the first. In the 1940s, Dr. Huggins of the University of Chicago discovered that prostate cancer was hormone-dependent, and based on these findings, hormone therapy was developed for prostate cancer, followed by breast cancer. Based on these results, the Nobel Prize in Physiology or Medicine was awarded in 1966. I studied at the University of Chicago, and the portrait of Dr. Huggins, shown here, was displayed at the front of entrance of laboratory where I studied. Every day I went to the lab, I would look at this portrait and think about cancer treatment. So-called cytotoxic anti-cancer drugs were also developed in the 1940s. The development of this agent was triggered by a mustard gas spill during World War II, which caused injuries for soldiers that were very similar to the adverse events of X-rays, including severe dermatitis, skin erosions, bone marrow suppression, and gastrointestinal disorders. Based on these discoveries, mustard gas was developed to have the same cancer treatment effects as X-bombardment. In 1943, cancer was reduced by the use of derivatives. However, the war was still going on, so all of these results were published in 1946 after the war. Based on these results, cyclophosphamide, which is still used today, was developed and is considered to be the first anti-cancer drug. In the 1950s, molecular biology flourished with the discovery of the double helix structure of DNA by Watson Crick and Franklin, and based on this, cancer research progressed rapidly. The Nobel Prize in Physiology or Medicine was awarded in 1962. Based on these results, molecularly targeted drugs began to be used in earliest in the 2000s for cancer treatment. A typical example is the approval of imatinib for Philadelphia-positive chronic myeloid leukemia, which was a big story at the time and was featured on the cover of the Times in 2001. Since then, much has also been learned about the immune mechanisms of cancer. The first Nobel Prize in Physiology or Medicine was awarded in 2011 in the field of immunology, and again in 2018 for the development of immune checkpoint inhibitors. In light of the above, immunotherapy of cancer has made significant progress since the 2010s and was featured in a special issue of Science magazine in 2013. What I'd like for you to keep in mind is that the radiotherapy was first used in cancer treatment after surgery, and that the current drug therapy is based on this treatment. From here, we will look at radiotherapy in combination with drugs. First, I'd like to talk about the combination of chemotherapy, so-called cytotoxic anti-cancer drugs, and radiotherapy. Radiotherapy combined with chemotherapy is usually concurrent chemoradiotherapy, which is also abbreviated as CCRT. CCRT is the current standard of care for almost all local advanced cancers and is used for all solid tumors, from malignant gliomas to cervical cancer, as shown in the list below. The year of publication is shown here, but regimens published in the early 2000s are still in use, and CCRT has been the standard of care for a long time. As you may know, cisplatin is also often used as a key anti-cancer drug, and 5-FU and other drugs are used in combination with cisplatin. The standard dose of radiation used is 50 to 70 gray and 2 gray per fraction. Let me show you the results of two representative clinical trials. The chemoradiotherapy for head and neck cancer is RTOZ 1911 clinical trial, in which cisplatin was used as an anti-cancer drug, and radiotherapy was given at 2 gray per fraction for total 35 times of 70 gray. The results showed that the larynx preservation rate and local control rate were both better than those obtained with radiation alone or with induction chemotherapy. In chemoradiotherapy for non-small lung cancer, platinum drugs and other third-generation cytotoxic anti-cancer drugs, such as paclitaxel, are also used. The standard dose of chemoradiotherapy is 60 gray in 30 fractions of 2 gray each. The two main goals of chemoradiotherapy are to increase the local efficacy and radiotherapy and to control metastases, but local control is considered to the more important goal. This table reviews clinical trials of chemoradiotherapy for head and neck cancer and shows that with respect to local control, chemoradiotherapy is as effective as radiotherapy alone with additional 12 gray of radiotherapy. Another meta-analysis of chemoradiotherapy for head and neck cancer found that although the overall survival rate is better than that radiotherapy alone, the main effect of chemoradiotherapy is primarily control local-regional recurrence and not so much to control distant recurrence. In other words, when chemoradiotherapy is given at the same time, the additional effect on distant recurrence control is considered to be low. The same meta-analysis was conducted for cervical cancer, and similarly, there is an additive effect on anti-cancer agents for both local control and distant control, but the additive effect is thought to be mainly for local control and to a lesser extent for distant control. On the other hand, there is a clinical trial called DECIDE for advanced head and neck cancer patients who received full induction chemotherapy. However, there was not much difference in local-regional recurrence. However, there were many adverse effects, and when induction chemotherapy was used, there are many deaths other than head and neck cancer deaths. Therefore, even though distant recurrence was suppressed, the DECIDE trial did not demonstrate the significance of induction chemotherapy compared to conventional chemoradiotherapy. The important point is that it seems possible to suppress distant metastases by using a large number of anti-cancer agents. Conversely, it is difficult to achieve distant metastasis control with the usual amount of chemotherapy drugs used in concurrent chemotherapy. In light of the above, I'd like to summarize some of the problems with chemoradiotherapy. The RTOZ 1911 clinical trial I mentioned earlier, which is a well-known long-term study, showed that the use of concurrent chemotherapy resulted in a very high rate of deaths other than cancer deaths. As a result, the long-term survival rates of radiotherapy alone and chemotherapy were almost equal. Thus, it is recognized that the local control effect is very good when used simultaneously, but the problem is there are many adverse effects. In addition, it has also been found that, for example, in esophageal and lung cancers, the heart is often irradiated, and when anti-cancer agents are added together, cardiac damage related to death is often observed. This is a result of lung cancer, and it has been reported that about 20% of deaths related to lung cancer are related to the heart, and these deaths may be related to the radiation dose to the heart. Another strategy for further improve the results of chemoradiotherapy is to increase the dose of radiotherapy, but it is difficult to increase the dose when chemotherapy is used together. For example, in the case of head and neck cancer, the 70 gray of radiotherapy was shortened to 6 weeks instead of the usual 7 weeks, which is effect an increase in radiotherapy dose, but the results were rather poor as a result of this. In the esophageal cancer, INT0123 clinical trial mentioned earlier, the results were also worse with 64.8 gray dose increase than with a 50.4 gray dose increase. In the RTOG0617 clinical trial for non-small cell lung cancer, the 74 gray group performed worse than the 60 gray groups. Radiotherapy combined with chemotherapy is positioned as a standard treatment for many locally advanced cancers, but there are many challenges. It is difficult to achieve distant control, and adverse events that may affect the survival outcome are considered problematic. We will now move on to the combination of molecular targeted drugs and radiotherapy. Molecular targeted drugs are often used in colorectal cancer and lung cancer. For example, in the case of stage 4 non-small cell lung cancer, if there is a genetic abnormality such as EGFR, KRAS, BRAF, or ALK, which are known as driver genes, the basic concept of recent lung cancer treatment is first use inhibitors or molecular target drugs corresponding to these genes. If not, immunological agents are used or conventional chemotherapy is used. Molecular targeted drugs for stage 4 non-small cell lung cancer with EGFR mutations are particularly commonly used. Gefitinib was the first generation of EGFR inhibitors, and recently, osimertinib, the third generation, has become the standard of care due to its better results in clinical trials. However, results have also shown that gefitinib may be better for Japanese patients. Gefitinib has been clinical use for a long time. For example, the NEJ009 trial, issued in 2019, showed that adding anti-cancer drugs to this gefitinib improves the results. Based on these results, for example, the 5-year survival rate obtained by adding the aforementioned clinical trial gefitinib plus chemotherapy was superimposed on the conventional 5-year survival rate, which is a survival curve for each stage used in the 8th edition of the UICC. The survival curves for the stage 4 patients treated with gefitinib and anti-cancer drugs are very similar to those for stage 1 and 2 patients, that is, those who undergo surgery. With the recent advances in molecular target drugs and anti-cancer drugs, some people think that these treatments are comparable to surgery, that lung cancer can be cured even with these treatments. However, what I'd like to draw your attention to is that, unlike surgery, these molecular target drugs, which are combination therapies of EGFR TKs and chemotherapy, do not reach a plateau in their survival curves. In other words, do not lead to the radical cure of cancer. Although the results are certainly improving, it is also clear that it is difficult to achieve a radical cure with drug therapy alone. This progression in drug therapy is certainly good, but it is also seems that the good point of radiotherapy can be added here. This EGFR inhibitor in combination with cetuximab and radiotherapy is currently the only clinical trial showing the addition of molecular target drugs to radiotherapy. Here are the results of famous Bona trial showing better results with the addition of cetuximab than with radiotherapy alone in advanced head and neck cancer. The overall survival rate was better, but the paper also noted that the main benefit was better local control. However, distant recurrence was not affected by the addition of radiotherapy alone and cetuximab. So, as with anti-cancer therapy mentioned earlier, the main additional benefit of cetuximab is local control. In the Bona study, this paper showed that the side effects were not different from those of radiotherapy alone, which survival was initially improved. This means that there are much anticipation that BRT with cetuximab will have fewer acute adverse events than conventional CRT. However, a series of clinical trials were also published that directly compare the outcomes of this BRT and CRT. There are two main clinical trials, RTOG 1016 and the de-escalation trial, both of which directly compared CRT and BRT in HPV-positive oropharyngeal cancer, and results show that CRT had a better overall survival rate and side effects were not so different. So this trial may have lowered expectations for BRT. Other trials have been conducted to evaluate cetuximab as an add-on therapy to the current standard of care of chemoradiotherapy, but none of these trials have shown an add-on effect. RTOG 0522 was conducted for head and neck cancer, and SCOPE 1 was also conducted esophageal cancer, and RTOG 0617 for lung cancer, but no effect was observed in any of them. Molecular targeted drugs, as the name implied, are thought to work specific against the molecular target of cancer and to have few side effects. However, long-term observation of patient data shows that they do not have few effects, and they have also caused specific adverse events. It has recently become known that angiogenesis inhibitors produce hypertension, diarrhea, and skin disorders, while ALK inhibitor produce lipid abnormalities and visual abnormalities. So molecular targeted drugs are very commonly used in colorectal and lung cancer, but unfortunately, they are not part of the standard of care in terms of combined radiotherapy. The Bonner study on head and cancer is the only one that has shown effective results, and it has not shown superiority over chemoradiotherapy, which is the current standard of care. In addition, side effects are not very rare, and specific adverse events must be taken into account when using chemoradiotherapy. We will then move to the combination of immune checkpoint inhibitors and radiotherapy. First, let's review the cancer immunity cycle. We know that cancer immunity has one cycle. Cancer cells release cancer antigens, which are first caught by dendritic cells. Dendritic cells then transmit information on cancer cells to T cells in lymph nodes and activate them, which is called the priming phase. Activated T cells migrate through blood vessels to the rest of the body, recognize and attack cancer cells, which is called the effector phase. However, it has been elucidated that within this immune cycle, there is a phase called the immune checkpoint, which has been used to keep cancer cells active. The immune checkpoint inhibitor mechanism working in the priming phase is CTLA-4, and the effector phase is PD-1 and PD-L1, and the brakes are released when antibody drugs are produced against each of them. This is the role and action of immune checkpoint inhibitors. In the past, for stage 4 non-small cell lung cancer, there are almost no 5-year survivors in the 1990s for chemotherapy alone. But recently, in the 2010s, clinical trials using pembrolizumab and chemotherapy have reported results with 5-year survival rates exceeding 50%. While the results of chemotherapy alone were also improving, these immune checkpoint inhibitors are now known to have a very additive effect. The use of these two types of immune checkpoint inhibitors and radiotherapy may further enhance cancer immunity, which is a strategy that is expected in the future. In particular, in this immune cycle, it is important to first successfully release cancer antigens and then to turn the cycle around, and radiotherapy is expected efficiently and effectively induce the release of cancer antigens, which is called immunogenic cell death. A representative clinical trial of this combination of immune checkpoint inhibitors and radiotherapy is the Pacific trial for stage 3 non-small cell lung cancer. In this trial, an immune checkpoint inhibitor was used as a consolidation therapy after CRT, which is a standard treatment, and it was proven that the survival period was significantly improved by this treatment. The important thing is that the addition of immune checkpoint inhibitors does not worsen quality of life nor cause many adverse events. Another very promising aspect of this immune checkpoint inhibitor is that the Pacific trial also shows that consolidation therapy significantly suppresses distant metastases. The CheckMate 577 trial in stage 2-3 esophageal cancer also shows that the perioperative CRT plus surgery with immune checkpoint inhibitor consolidation was effective. And in this clinical trial, it has also been shown that the immune checkpoint inhibitor consolidation suppressed distant metastases. So far, chemotherapy and molecular target drugs has been presented as radiotherapy in combination with drugs, but both has been found to be less effective in suppressing distant metastases. In contrast, immune checkpoint inhibitors suppress distant metastases very well. This is where the combination of radiotherapy and immune checkpoint inhibitors showed great promise. Radiotherapy in combination with immune-related drugs, in addition to immune checkpoint inhibitors, is expected to create new cancer treatment. It is also highly comparative with radiotherapy in that it is highly effective in controlling distant disease, unlike conventional drugs. However, the medium to long-term adverse events are still not well understood. From the standpoint of the radiotherapy, another point is that radiotherapy doses can be increased even when used in combination, and these are expected to be new treatment in the future. Needless to say, the new treatment for cancer is one that strikes a balance between local control, distant control, and adverse events, which are in conflict with each other. A new role for radiotherapy that pay attention to these three aspects is expected. Finally, I will summarize and discuss future radiotherapy based on these current conditions. This is a result of stereotactic radiotherapy (SRT) showing the local effect of typical radiotherapy. SRT is now recognized as a standard of care for stage 1 non-small cell lung cancer. Until now, fraction radiation methods such as 66-gray 33 fractions has been used, but this SRT was first developed by Dr. Uematsu in Japan in the 1990s and is now used worldwide because it is extremely effective and has few adverse events. Clinical trials comparing these methods has shown that SRT using higher doses of 18 gray or 12 grays per fraction is more effective locally than the usual fractionated radiation method of 2 gray or 2.5 gray per fraction. Under the condition of radiotherapy alone, there has been an attempt to increase the intensity of local treatment by increasing the dose, specifically by increasing the dose per fraction, and this has all shown to be effective or to cause fewer adverse events. For example, in early-stage bronchial cancer, the efficacy and the side effects are almost same with 2.4 gray per fraction compared to 2 gray per fraction in the past. The recently in the phase B clinical trial for prostate cancer with 5 fractions of 7.25 gray per fraction. The efficacy and adverse events are also almost equal. In the non-small lung cancer mentioned earlier, 13.75 gray per fraction was used in the JACOB 1408 clinical trial, and for metastatic brain tumors, doses of 20 gray or more per dose have been used in stereotactic irradiation for some time. Recently, it has been found that even in the case of distant metastases, if only a few distant metastases are present, the overall survival outcome can be improved by adding local radiotherapy and treating the local area well. The STAMPEDE trial for prostate cancer shown on this slide is a representative example. The Cerebral Comet trial showed that the stereotactic irradiation of a small number of distant metastases improves the overall survival rate. Thus, it is now recognized that local or metastatic radiation control is very meaningful even in the presence of distant metastases. It should be noted that the stereotactic irradiation doses used in the Cerebral Comet trial was 7 gray or higher per fraction, which is quite different from the fractionated radiation used in conventional chemoradiotherapy. We have discussed the combination of drug radiotherapy and radiotherapy, including the historical background. Radiotherapy, in particular, is a typical treatment that allows local control, and by using immune-related drug here, distant control can be achieved. Furthermore, if both of these therapies have few adverse events, I believe that it will be possible to control adverse events and improve the overall survival outcome. Finally, let me return to the picture of Osaka Castle. Radiotherapy should play a central role in the future of cancer treatment. I'd like to repeat once again that radiotherapy was the first cancer treatment other than resection, and the current cancer treatment is based on these results. I'd like to conclude this lecture with a common understanding that radiotherapy should play a central role in the development of future cancer therapies as well, just like this Osaka Castle. Thank you very much for your kind attention.
Thank you very
Thank
much.
you. Thank you, Dr. Nakamura. That was very thought-provoking lecture, and I think a lot of us have thought on many cases in your head.
Yeah.
We would like to, do you want to add a few words after the lecture, Dr. Nakamura, or should we move on to panel discussion?
Yes. 僕が始めたらいいんですか？
いや、何か追加もしありましたらっていうだけですけど、いいですか？
Yes.
Thank you. We would now like to invite the panelists for today. We have neuro-oncologist, medical oncologist, and radiation oncologist for the panel discussion. And before we move on, we have we will all the panel discussion can turn on the video, please? Yes, you have already. Thank you. We have Dr. Sith from Thailand, Dr. Ganzen from Philippines, and Dr. Shimokata from Japan. And can you all introduce yourself briefly in the beginning? Dr. Sith from the start.
Sure. Thank you very much. First, I'd like to thank the FARO organizer to inviting me today to share some thought and views about management of, I guess, brain metastases. And I'm a neurologist by training, and I did further training in medical neuro-oncology. So I focus my practice in primary brain tumor management, but some on brain metastases and leptomeningeal metastases as well. So thank you.
Thank you. Dr. Ganzen, please.
Hi, I'm Dr. Ganzon. I was initially a medical oncologist, still a medical oncologist. I started my oncology practice way back in the 1990. And after 10 years of practice in medical oncology, I switched to radiation oncology. And I'm both a medical and radiation oncologist.
Thank you. Dr. Shimokata, please.
Yes, good evening, everyone. Thank you so much for inviting me to this FARO webinar. I'm a medical oncologist from Nagoya University Hospital. And today I would like to comment from the standpoint of a medical oncologist. Thank you.
Thank you all. So I'd like to start the discussion. The discussion point today I have for you is whether the approach to advanced cancer will change in the future with the advent of immunotherapy from the standpoint of each individual neuro-oncologist, medical oncologist, and radiation oncologist. So first to medical oncologist, systemic disease can only be treated by systemic therapy. We've learned that. And it's true, but with immunotherapy, can combination of immunotherapy and SRT, stereotactic radiotherapy, to selected site be a game changer? Can we still cure those systemic disease? That's the question point. And while the concept of oligometastasis has been a hot topic discussion, this recently is a hot topic, it's also been debated that perhaps the concept does not fit well all. So what cancer or condition should we call true oligometastasis, and meaning which or what kind of metastasis should we choose to treat SBRT or SRT or SRS rather than just systemic therapy? So first, Dr. Shimokata, do you have any point on any argument on this topic? The immunotherapy, with the immunotherapy and SRT can be the game changer or not? Or do you think there is some patient with systemic disease that will be very can be treated with SRT or not? Do you have any comment on that?
Thank you, Dr. Kawamura. I think it can be a game changer in some patients. Radiation could be combined with immune checkpoint inhibitors to improve the local effect of radiation radiosensitization. And the radiation could be used to improve the systemic effect of immune checkpoint inhibitors, such as abscopal effect. The rationale for the induction of abscopal effect was mainly based on non-small cell lung cancer studies, especially PEM-PRORT and MDSCC. This trial is showing that an addition of radiotherapy significantly improved response rate, PFS, and always about doubling time. So especially an oligometastatic disease is a good target, I think. But there were no clear criteria for the diagnosis of an oligometastatic disease. According to the ERTC survey, the number of metastases and metastatic organs considered to be oligometastatic disease and varied among the investigators. With the most common response being less than 3 metastases in 2 organs, excluding the primary lesion. And based on these findings, ERTC published a consensus report defining synchronous oligometastatic disease as 5 or fewer metastases within 3 organs, with all regions amenable to local treatment. But several trials have been conducted, but the eligibility criteria were various. But at least I think patients must have a stable disease after standard pharmacological therapy, and the number of metastases must be small. But based on this information, it's necessary to make a judgment and to construct a new definition of the metastatic disease. Thank you.
In which condition do you think it's stable? Can you say it's stable? I mean, after 6 months, 3 months, it's very difficult for some
very
cases.
difficult.
Do you have any suggestion on that? Like first line chemo, and if patient is somewhat stable for 6 months, then the patient had only 2 meds. But some may think maybe a month later, he's gonna have another 2. So when can we call them stable? Is there any, just your opinion is fine.
In my opinion, for at least 3 months stable, it's well, 3 months or
At least
I
3
think
months.
so.
Thank you. Sorry, that was a mean question. I know, sorry. I think this oligomets is first really like SRT was first applied to brain mets a lot, because brain mets was a little bit different from other mets, that the brain is guarded by BBB, and it acts differently than other body metastasis. So I want to ask Dr. Sith if immunotherapy may change the therapy of brain metastasis. That right now we are trying to treat like 10 or 15 metastases with SBRT, not NOBI, SRT, SRS, but and we are trying not to use prophylactic whole brain irradiation. So if immunotherapy can replace the prophylactic whole brain irradiation, when should we use whole brain irradiation, and to which patient should we use immuno and to which patient should we use SRT, SRS? Do you have any comments on that?
Yeah, well, it's probably not just limited to immunotherapy, systemic therapy in general, but for selected cancer. As you all know, non-small cell lung cancer with EGFR mutation or ALK-ROS alteration, that newer generation targeted therapies, kinase inhibitors, have activity against this. And we have seen a response, nice response for brain metastases as well. And I think and melanoma with BRAF mutation as well. So immunotherapy, as you all know, we using anti-PD-1, CTLA-4, or in combination can produce a nice response, particularly for melanoma from the original studies. But for other cancer, we have seen some response as well. But not all patients do have response to immunotherapy, the checkpoint inhibitors, and majority of them, the responders, have to have certain biomarkers, for example, like PD-L1 expression to some extent. So not everyone will benefit from this, but we're still learning to find the right biomarker for selecting patients who's going to benefit from immunotherapy. Now for SRT, I would say, yeah, it's like Dr. Kawamura said. So in the past, when I was a medical student, metastases 1 to 4, we call oligometastasis. Now it's look like changed to more than 10 to 15, like you just said. And I guess in the future, it's probably it's gonna be more metastases that we're gonna treat with stereotactic radiosurgery or stereotactic radiotherapy. So like you said, the place or indication for whole brain radiotherapy becomes less and less as we use SRT more and we have more effective systemic therapy. Yeah, so and the whole brain radiotherapy therapies, in my personal view, is probably for patients with poor prognosis, but not that poor that we learned from the study that if the patient has very poor prognosis, it's not different from a best supportive care. So a patient with poor but not very poor, with a lot of metastases, a lot of systemic disease burden, not responding to steroid to control the symptom in the brain. So whole brain radiotherapy is probably good. Or another setting is probably patient with limited brain metastases, but not amenable for SRT or surgery by some reason. So using whole brain radiotherapy is probably an option for these patient population. Yeah.
Thank you so much.
I have a question. Is that okay?
Yes.
How many patients will benefit from the immunotherapy for the brain metastasis, not molecular targeted therapy?
You said how many patients?
Yeah, how ratio or lung cancer or breast cancer?
Yeah, well, so it depends on which agent we use. So monotherapy of PD-1 or PD-L1 response rate is about, I was, from the data, it's like 20 to 40%. But when you use combination, it can be up to 40 to 50% in some series. But yeah, I think we're not gonna cure patient with just immunotherapy, particularly for brain, that we learned that the microenvironment is different from other cancers, and this is a bigger problem for primary brain tumor like glioblastoma, as you know, that immunotherapy do not work because microenvironment is, is cold, so immunologically cold. So there's not a lot of T cell infiltration, a lot of macrophages. So if we have strategies to turn these microenvironment to be, more immunogenic, that may be a way to go. And a lot of people now try to explore the use of oncolytic viruses to change the environment, and or combination of immune checkpoint inhibitors, not just CTLA4, PD1, PD-L1, but other checkpoints, for example, like TIM3, or other checkpoints.
Thank you.
Thank you. That was a great discussion. We are lucky to have both medical oncology and medical radiation oncology on his learning. That Dr. Ganzen has two points of view, I think, as a radiation oncologist and as a medical oncologist. So do you have any comments on those, our discussion we have?
Hi.
Dr. Ganzen.
Sad to say, my practice is on the treatment of metastatic disease and very advanced disease. So I get referrals from my medical oncology colleagues mostly for palliative treatments. So they are usually on systemic treatments because of metastatic disease, and when they have problems, local problems resulting to bulky lesions, that's where they send patients to me for palliative treatment. In that context, I have two interesting cases wherein the tumor is known to have radio-resistant qualities. They are renal cell cases, and renal cell cancers are usually sensitive to immunotherapy and targeted treatments. So in the last year, I have two cases very interesting that they responded well to radiation treatment while they are on targeted and immunotherapy. So if I can share these two cases, can you allow me to share these two cases?
Yes, please.
Okay, so let me share.
I can see.
Yes. The first case is an elderly female who presented with very huge mediastinal mass and presented with vomiting and difficulty of breathing. And finally, after several months, it was documented that this tumor is a renal cell carcinoma stage 4 and was subsequently started on sorafenib, a targeted treatment, and a gastrostomy tube was inserted. However, there was progression of the difficulty of breathing. So patient was sent to radiotherapy for palliative treatment. So this is the tumor, as you can see in the CT scan, a huge tumor. Usually renal cell cancers are bulky tumor, even in the metastatic lesions. You can see here a huge mass that really compresses the whole mediastinum, including all the vessels, all the compartments, including the airway and the esophagus. So we just treated this patient with a simple IMRT of 30 gray and 10 fractions. And we were surprised that there was a marked improvement of this tumor. On the left is the original tumor, and after 9 months of follow-up, you can see that the tumor, the gross, huge tumor, residual, there's only a residual tumor left, and patient has marked improvement. And I am sure that this was not an effect of the sorafenib, because the reason the patient came to us again 9 months after is that the patient has progression of other metastatic disease. She presented with bulky soft tissue vertebral mets, and presented with inability to unable to walk because of the mass lesion compressing the vertebra. So we treated again with the palliative treatment of 30 gray in 10 fractions. Good enough. Patient was able to walk, very marked improvement. However, we were not able to get an image of the how much reduction in tumor, but I would assume that we have reduced the tumor as we have noted in the mediastinum. However, patient came back for brain mets, huge brain metastasis, and the patient presented with seizures, and eventually succumbed to infection because of massive steroids that has to be given to control the neurologic side effects of the patient. So what we've noted is that previously, I don't expect good responses of renal cell carcinoma with radiation, but I have noted that patients on targeted treatment, because of systemic treatment, they were given either TKIs or immunotherapy. The focal lesions that where we treat with radiation treatment has a good response, though the overall outcome is the same, but the local control and the effect of radiation is markedly good in the area that we need to radiate. And a second case, just several months ago, is a younger female, a known case of metastatic, poorly metastatic renal cell carcinoma, and presented with a very big mass in the pelvic up to the acetabulum. There was a very huge mass, and patient presented with a very severe pain. No amount of painkiller can control the pain. So because of that, patient was referred for palliative treatment of pain. And so we treated it with 30 gray in 10 fractions, but I added, because of the bulkiness of the tumor, I added extra 15 gray to the tumor. And 2 weeks after, patient is no more in pain meds. Pain was controlled, and there's no need to even have a rescue meds. So I think local treatment of radiation works well with those newer agents. I do agree with the lecture. The future is still giving radiation, especially for bulky tumors, for locally advanced tumors. The systemic treatment cannot really be enough, to control a bulky, or if there's an increased bulk of disease. So the radiation would be very helpful to reduce the bulk and improve quality of life of the patient. So I think radiation will still be a mainstay with future treatments together with the newer agents. I can see better responses of radiation with these newer agents. That's all.
Thank you, Dr. Ganzon.
I have to stop sharing. Yeah. Okay.
Yeah, we must not give up.
Dr. Nakamura, please. Yes.
Yeah, we must not give up. It's very impressive cases. And did you see the abscopal effect in the first case? It's very effective for the radiation therapy.
Yeah.
Yeah.
I was surprised that there was marked reduction in the tumor bulk of the bulky tumor. And even 9 months after, we still have a good control of the area, even though the other metastatic area progressed. No, so I think the systemic treatment is not really working. It's progressing in the other metastatic side, but the area that we treated with radiation has a very good control, even after 9 months.
Thank you. My question to you is that I really agree that palliative radiotherapy is very, very important. And however, there are 30 gray in 10 fraction, or maybe even 45 in 15 fraction, is not really enough to really control the tumor forever. I mean, that's not curative dose. But so sometimes we after like 6 months, we experience that it start to regrow. So we sometimes really get into difficult cases to decide if we should go a little bit more than 30 gray in 10 fraction or 45 gray in 15 fraction rather than, I mean, and that's those kind of choosing cases. Do you have any insight or any how do I say, anything that you put on your mind that this case you go for more than, you try to eradicate with somewhat curative intent? It's metastasis, but it's in like to try to go for higher dose. But in these cases, you don't go that much. Do you choose those? Do you have any?
Are you asking directly the question to me?
So yes,
Okay.
I'm asking to
in my
Dr.
experience,
Ganson.
what I do is that I look at how big is the tumor. Is the tumor volume that I look. If I can see that the tumor is that big, I would not stop at 30 gray in 10 fractions. But what I do is that I initial volume 30 gray, and then I wait 2 to 4 weeks after if there's a need to give further. There was a tumor, bulky tumor, that I gave 2 batches of 30 gray in 10 fractions. And I was able to achieve, that was a tongue tumor. Yeah, a 90-year-old female. We presented this case at ASCO, just an oral presentation, wherein at base of tongue tumor, an elderly female, huge mass that we treated only with radiation, no systemic treatment because she's that old, and we were able to achieve a complete response with 2 batches of 30 gray in 10 fractions, and the patient followed up to about 1.5 years with good local control. So there's no distinct guidelines. We just have to see the results. I treat in batches, and I give about 2 weeks to about 4 weeks to see if I need to give more.
More like quad shot type of variation, maybe. Thank you. And there is a question from the audience. I think this will go to Dr. Nakamura and Dr. Ganson. Can you see the Q&A? What do you think if we give the metastatic site let's say 30 gray in 10 fraction, but make a portion of the tumor hotspot, like inside, for example, middle of like 50 gray. We actually do that with brain metastasis with gamma knife, but we built very high dose in the middle. Can this make the tumor more immunogenic? That's a tricky question. With the higher dose in the middle would make more immunogenic. What do you think, Dr. Nakamura?
Yeah, I think it could be. I sometimes use this kind of the higher dose to the bone metastases sometimes for the good case. We not only the 30 gray, sometimes use the more higher doses.
Dr. Ganson, do you have any comments on this?
My observation is on the local control. The 300 fractionations, I think, has another benefit of also fibrosing or devascularizing the area. I have noted that when I give 300 gray fractions, we have longer control because your tumor to regrow will need a vascular supply. So if you give a 300 gray fractionation and it can devascularize and it can fibrose the vessel, it will not be able to sustain a growth, and you will be able to produce a longer control. I think I think we're now seeing that from the traditional concept that the radiation only works on the genetic materials, I think other parts of the tissues has an effect that contributes to the overall tumor control. Isn't it? In the systemic treatment, they use Avastin to stabilize the blood supply of the tumor, and they notice effect. I think that's also an additional effect of hypofractionation to the vascular area of the tumor. That's just my observation. I don't have any proof of that.
Thank you. I think this is a really good topic that maybe Dr. Sith can make few comments, because it's gamma knife. We built very high dose in the middle, but with Liniac, we don't build that much to the center. So if you see any difference between gamma knife and the Liniac SRS, that may be a little hint to this question. It's difficult, sorry, but if you have any comments on building.
I don't know that I can comment on this, but for using radiotherapy to evoke immune response, I think is a good concept. But I think we probably need more clinical studies to prove that really happened for brain, particularly for brain tumor, brain metastases. But yeah, I agree with the concept that it may help with the immunotherapy to work better. Yeah.
Thank you. Sorry for asking difficult questions. We have another question from the audience. I do agree that as a radiation oncologist, we should be confident to prescribe radiotherapy to relieve tumor burden in any setting of inoperable tumor with hypofractions, considering the hypoxic status at the center of tumor. Yes. Regarding the microenvironment of the tumor itself, what would you suggest to identify this situation? Will PET be helpful, or maybe I don't know, CT CAT scan or other MRI? What would be more helpful to, let's say, to select patient with who would benefit for the higher dose in the center. Do you have any comments on this? Does anyone have any comments on this? Dr. Nakamura?
I think the PET is useful for the very active points of the tumor, and it could dose escalation to the active part of the tumor. One of the considerable idea, I think.
Do you put more dose to the hot spot, or do you put more dose to those with the hypoxic area? I think that appears to be cold in PET.
But technically, it's difficult. The center of the tumor is good for the higher dose or for the technical reason. So usually I use it.
Thank you. Do any other panelists have comments on this?
Can I share another case? Okay. I think about a year ago, I have a very large germ cell tumor in the abdomen that occupies almost 2/3 of the abdomen. And the problem is the tumor is bleeding, and even the angiographer, the one who identifies which blood vessel is bleeding, they're not able to see what vessel is bleeding. So out of desperation, they referred to us if radiation can do something, because these patients in the ICU, they are transfusing, I think, 4 liters of blood every day. So we just tried. What I did is 2/3 of the whole abdomen is the tumor. I just treated the center because I surmised that the bleeding point is most in the center. So I gave 20 gray in 5 fractions. The tumor stopped bleeding, and the tumor was controlled, reduced in size, and the patient was able to undergo induction chemo because the bleeding stopped and the tumor regressed. And after 6 months, I was able to give a consolidation RT radiation to the abdominal, to the residual. I think the residual tumor is just about 15 to 20% of the original tumor, and the patient, I saw the patient up to 2 years after, still alive. So I think hypofractionated treatment can work magic to the desperate situation of bulky, very aggressive tumor in the setting of bleeding, pain, and compression and obstruction.
Did you consider using 8 gray in 1 fraction instead of 20 in 5?
I don't have any idea at that time. I just treated the usual dose regimen for SBC, for SBC treatment of 20 gray in 5 fractions. I don't have a guide. I just need to treat the patient to stop the bleeding. That's my only objective. And I was surprised that not only the tumor stopped bleeding, the tumor reduced in size to, with the RT alone before the induction chemo, to 50%. So, and they did induction chemo, and the tumor was further reduced to about 20%, wherein that's the time that I consolidate with RT.
Thank you. So it's about time. Thank you so much for all the audience and the participants, and of course to panelists, speaker, everyone. Thank you so much. And I think that was very really thought-provoking theme. So I think a lot of us have learned a lot from others. If any of the panelists have any additional comments that you really want to share here, that's your last chance. Do you have any comments on? No? Dr. Shimokata, do you have any do you want to add a few comments in the last?
Oh, thank you. I have no comments.
Sorry for putting focus on you. Dr. Sith, do you have any comments?
Nope. Thank you.
Thank you, Dr. Ganson.
No, I think I've said a lot.
Thank you. Dr. Nakamura, do you have any comments?
Oh, thank you very much. I enjoyed discussing this with all of you. Thank you very much.
Okay, thank you. So JASTRO is having the annual meeting in November 10th to 12th, and hosted by Dr. Nagata. He was here. He is here, I think, but I guess he doesn't have any comments on this, so we can close this session. Do you have any words, Mayank? Do you want to comment on whole session? Dr.
That's
Mayank?
okay,
No?
Mariko.
That's okay?
No.
Okay.
Yeah.
Okay, so we already had the photo, so I think this is all for today. Thank you so much for joining us. And I hope we'll see you on next FARO webinar in September, right?
Yes, right.
Thank you.
Thank
Do
you.
we
Thank you,
close?
everyone.
Thank you. Have a good evening.
Thank you. Have a good
Thank you,
evening.
everyone.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye.
Bye.
Thank you. Thank you, Manny.
Thank you. Thank you very much, Mariko.
Thank you.
Have a good night.
You too. Thank you.
Bye,
Thank
Mariko.
you, Dr. Ozawa. Thank you. Are we gonna close? 小沢先生、ありがとうございました。
ありがとうございました。もう先生します。Thank you.
します。Thank you.